and welcome to the latest Spotlight on interview. Today we are going to be talking about the role that genetic counsellors play now and also in the future within healthcare. So before we kick off, Beth, if you could just introduce yourself and tell everyone a little bit about what you do as well.
So my name is Beth Coad and I am an acting Principal Genetic Counsellor at St George's Hospital in London, and I'm also a part-time Honorary Clinical Lecturer in Cancer Genomics. So I'm really lucky that I have a bit of a split role. So in my St George's Hospital role, I'm a clinical genetic counsellor, so I see patients mostly in cancer these days and take them through the process of genetic testing and support them with that. And in my lecturer role, I'm involved in creating a lot of online learning resources, in particular, in order to train up the medical workforce in kind of cancer genomics and helping them to be more prepared for ordering genomic tests.
That's really exciting. How did you kind of get into your role as a genetic counsellor? Like, what made you want to go into it, and what was the kind of path to get there as well?
Yeah, so I think, like quite a lot of genetic counsellors, we often say we had an interest that we really like science and are interested in science and biology and you know how things work. But the kind of laboratory side was maybe not as much for us, because we all often have a real kind of pull to being involved with people and talking to people and supporting patients. So it was really just kind of trying to find a career that balanced those two things. And it was actually, I was really lucky. I had a biology teacher all the way back when I was in school, sort of vaguely mention it to me. And then sort of throughout my undergrad doing science, I looked into kind of psychoms and all those sorts of things. And in doing the research around that, that's where genomic and genetic counselling came up. And it's just kind of sounded like my dream job. I get to be a nerd and be interested in the science, but I get to talk to people every day and help them with really kind of complicated, complex issues. So yeah, it's a real dream job to be able to do.
Yeah, and how kind of, in your opinion, what is the importance of kind of genetic counsellors in today's society? Like, why is their role so important in healthcare?
So the role of a genomic or genetic counsellor is one that is quite unique and unusual in healthcare for a few different reasons. I think that counsellor part of our name is something that we're really lucky that we all get training in counselling skills, and a big part of our job is looking at how we can support patients and really take a kind of holistic view to a patient when we're taking them through genomic or genetic testing. And I think also we, as part of that, also have slightly longer appointments with patients, which is really nice, and are able to provide that bit more support. But also in terms of the genomics and the genetics, it's a really specialist part of healthcare that a lot of the time isn't necessarily part of healthcare training. So to have individuals who really do have those skills and that knowledge base to be able to support patients, but also to be able to support their other colleagues in terms of helping them in ordering genomic testing, and kind of thinking about the healthcare services now and why genetic counsellors are so important currently, is that we know that genetic testing is growing and expanding, and more people are offered tests. And these are tests that can really make a difference to their lives or their cancer treatment, for example. And those can be really complicated and complex tests. So having highly trained individuals that are easily accessible are a really a kind of useful resource that we have. But sadly, there are only so many of us at the moment. I think we need a few more for the needs that are coming, certainly.
Yeah, I mean, your role is so patient focused. How are the kind of genetic counselling practices ensuring that they are kind of patient-centered?
Yeah, so I think that's really something that we have almost from day one built into most genomic counselling training, is really looking at that patient in a kind of holistic way and having that patient-centered approach. And in genetics, when we're talking about a patient-centered approach, it's really important to remember that we actually mean the entire family. When you do a genetic test, you're not just getting information for that one individual like most other healthcare tests do. You're actually potentially finding out information that can affect an entire family. So that's a real part of our approach, is looking at the person in front of us, what that family network around them might be, what their support network might be, how this genetic test result may impact them and their life, and thinking about how we can best support them going forwards. So we've always had that as sort of the grounding of what we do, is putting that patient at the centre and doing everything that we can in order to ensure not just that we're obviously giving them the appropriate information, we're trying to give them what is really quite complicated information in an accessible and understandable way, but also consider the psychological implications of this testing and how we can support them with that as well.
A kind of question that kind of backs off from your answer is an important part of your role is obviously giving people a diagnosis. How do you kind of deal with those situations and ensure that you're kind of that the patient fully understands the diagnosis and that you're kind of offering support? Like, what's that kind of chain of events like?
Yeah, so it can be it can be quite a difficult part of our role, that occasionally breaking what might be seen as a bad news diagnosis, that you do have an inherited cause of a particular health condition, and it really varies what we do. And so we vary our approach slightly on what that result might be. So in my field, I work mostly in cancer. And so a lot of the time when I'm doing diagnostic testing, I've got someone sat in front of me who's got a diagnosis of cancer. So I'm not the one giving them that diagnosis. I might be giving them a reason why they had that diagnosis, perhaps, and sometimes focusing on the why and also the what we can do. So in the case of cancer, are there treatment options that actually, because you've got this genetic change, actually we may be able to target your cancer a bit better than we would have done if you didn't have this genetic change? And what can we do in terms of risk reducing options or screening options for yourself in the future, and also your family are at risk? So I think that's a big part of it, is highlighting that if there are options, there are options. But other times in genetics, we might see patients where there aren't necessarily those treatment options currently. And it's about learning to live with a genetic condition and accept. And it might be our role as genomic counsellors in part to kind of prepare them for that before they've had the test and before they've had that result, and spending some time talking through that and helping them be in a good place for when they do get that result. Or it could also be looking at kind of onward support. So whether that's thinking about patient support groups we can connect people to, whether that's actually for some people involvement in research studies can be a really helpful form of support, thinking about options in the future. And sometimes we can be that kind of guide and that pathway, and really connecting patients up with lots of different services in a way that, again, maybe there aren't as many other roles of people that can do that. So that's also a big part of what we do.
You must come across so many kind of complex situations. Like you mentioned, obviously, when we get a genetic test done, it's not just impacting us, it's obviously then going to impact our family as well because of the genetics. What are some of the kind of complex family dynamics that you've come across, and how have you kind of dealt with those situations?
Yeah, so I mean, we all have families and we all know how complicated families can be. As soon as you've not just got that patient sat in front of you to think about, it can get a bit more complicated. And so we certainly have examples with genomic and genetic testing around the right not to know, and that sometimes people really won't want this piece of information, and they don't want to know that they've got a genetic risk. And everyone does have the right to not know that, but we may have a challenge that perhaps that person's child may want that piece of information because actually they might want to consider the risk reducing or screening options when we're thinking about those inherited cancer risks. And so in those circumstances, we can have a challenge where we deal with working with our patient to maybe give them the information they need for their healthcare decisions and choices, but considering that their genetic test result, in when we see autosomal dominant conditions, will actually be giving the result for their parent who might not want that piece of information. And so it's kind of working sensitively with families in order to try and, again, prepare them and consider the best outcomes that we can have in that circumstance, but also at the end of the day, putting what's in the best interest in terms of our patients in front of us healthcare needs at the real forefront.
Another ethical challenge that you face that's kind of similar to the kind of family dynamics is predictive testing in children. How do you ensure that there is that patient autonomy in these cases for children where they're not choosing to make those decisions themselves, I suppose, especially when they're really young?
Yeah, so when we see adult onset conditions in genetics, so again, a lot of those cancer predisposition syndromes we're talking about, so things that people might have heard of like BRCA, or another common one is Lynch syndrome, where there's the increased risk of bowel cancer. In those kind of conditions and other neurodevelopmental conditions, again, like Huntington's disease that happen in adulthood, we don't usually test children for those conditions because they have no control over that decision when they're a child. It's taking away their autonomy by doing that test in their childhood. And so we generally in genetics don't test for those conditions because it's usually not in the best interest of the child. There's no healthcare interventions we can do at their current age. And we encourage families to talk to their children about the genetic condition. Isn't something that should be kept a secret. And we know from research in our area that talking to families and giving small bits of information in an age-appropriate way is really the best thing to do, so that when children are adults and they are kind of over the age of 18 and able to consent to this testing, that they can really be involved in that process and they've been given that information over time, and it's easier for them to adapt that way. But there are some circumstances where there are genetic conditions that obviously can impact a child's health, and having a diagnosis can be helpful for them, whether it's accessing a treatment option or actually whether it's potentially accessing care services by having a diagnosis and a name for their condition. So in those cases, it's about balancing the best interest of the child. And in those cases, it is in their interest to do that test. And we will do genetic testing in children in some circumstances. Yeah.
Within your role, you obviously come across those different people from kind of different backgrounds, different communities, different beliefs, and everything like that. What ways are you kind of adapting your services and the way you communicate to ensure that you're communicating sensitively with, for example, transgender patients?
Yeah, so you're exactly right. Like any healthcare services, we see all sorts of people, and we really are conscious in the world of genetics now to try as best as we can to be an accepting and an inclusive service for everyone. And we really do want as many people as possible to be able to be accessing genetic testing that may be helpful to them. And so in the example of trans patients, I am involved with a group who are currently working to improve kind of general access and care for trans and gender diverse patients who might have an inherited cancer condition or may have a family history of cancer that means that we might recommend some extra screening. And so there's a group of us currently working on that with the UK CGG, the UK Cancer Genetics Group, to create some more guidelines in that area. And so far, the work we've done, we've looked at some cases, and we're hoping to involve some kind of patient groups and some charity groups in that as well. And so some really simple things that we're able to do is when we think about our family history questionnaires. So when we in Cancer Genetics here at St George's invite people to our service, we ask them to fill out an online family history questionnaire. And we will ask them their gender that they identify with and give a list of different options, as well as being a man, including transgender men, or woman, including transgender women, also non-binary options, or also the option to put other and include a free text description. And then we ask people if their sex assigned at birth aligns with that gender, because for us it is important to have that information about sex assigned at birth, because that can affect cancer risks in these inherited conditions. As well as that, we also just include some free text options so that people can explain if they've got a relative who is transgender, for example. You'll also see us regularly wearing things like badges in our team. So we have the NHS rainbow badge is one symbol that people will know, and you'll also see some of us with a little rainbow DNA badge as well, and also pronoun badges, and asking patients things like what their preferred pronouns are. When you've drawing a pedigree, explaining things to them and thinking about what inclusive pedigree symbols we can use as well. So for example, ensuring that you're using the pedigree symbol, which is our family tree drawing. We would usually draw a square for someone who was assigned male at birth and a circle for someone who was assigned female at birth. But actually that binary system doesn't capture people's gender identities and doesn't capture transgender individuals' identities. And so we, from using guidance from patient-led research in the US, are currently using the symbols of the gender that someone identifies with and considering an alternate symbol for non-binary individuals that we still need a bit more research in the field to kind of pin down. But at the moment, that kind of alternate option with really clear labeling is what we're using, and just working with patients and talking to them about what they prefer and what language we can use to be more inclusive as well. Whether that's using tissue-specific language and thinking about using a term chest or breast and asking a patient what's more comfortable to them, thinking about people who have ovaries or people who are pregnant, as opposed to automatically jumping to women who are pregnant. All of those things are different ways that we can adapt our services and are kind of recommending that we do. And we're really lucky as genomic counsellors that we are that kind of patient-centered approach, and we really are in a good place to push this forward. And we have the support from the Association of Genetic Nurses and Counsellors who have put on training in this area. So it really is a field that we're working on getting better at, I think is where we're at the moment.
Yeah, no, that's really, really interesting. I think the patient kind of led research is so important. And as you said, you're learning as you go, and you're trying to kind of be more inclusive and speak to people and kind of see how they want to be kind of communicated with. So it's really, really important. What are some of the challenges that you think genetic counsellors will face over the next kind of few years?
I think a big challenge for us that we're starting to see now, but is only going to increase, is mainstreaming genomic testing. So when I say mainstreaming, I mean genomic testing outside of the realms of these individual little clinical genetics departments that are kind of tucked away, in our case, in the basement. It's not really extending that testing to as many people as we could. And so a big part of the future in the NHS, but also in healthcare systems across the world, is making genomic testing available at the point of treatment and care for patients. In my field of cancer genomics, that's something that means we can get test results in time to support personalised cancer treatment for individuals, which is hugely important. And while that's an amazing thing and really helpful, that's a really big challenge, because that's a huge more number of people firstly accessing the testing and potentially having results that they need support with. But it's also a huge number of healthcare professionals who traditionally don't have brilliant training in genetics and genomics. And supporting those healthcare professionals to feel able to consent patients to testing, to be able to give them appropriate results, also to be able to deal with the increasingly complex results that we get. So variants of uncertain significance are things that we're seeing more and more of the more genomic testing we do. And those are variants that we're not sure if they're just part of normal variation or if they might explain a person's, say, cancer diagnosis, for example. So when we get those, they can be a really challenging result to interpret, and also to think about what care decisions to make for that patient based on that uncertain result, where we wouldn't normally want to be saying, for example, doing a risk-reducing surgery based on something we're not sure about. So supporting our wider healthcare professional team in giving those results and helping patients, I think, will be a really big part of the role for genetic counsellors in the future. Also, that kind of widespread of genomic and genetic testing, it would be lovely if it became something that was much more normalised in society, and that it was something that more people were able to access to help themselves in whatever form of healthcare it might be. And again, that kind of widespread will need a bit of support in genomic education in the public. We kind of taught maybe a little bit of genetics back in GCSE, but lots of people weren't when they were back in school. And so it's helping people to feel a little bit more alert and aware and have that autonomy and empower themselves to kind of explore the potential genetic information and their family histories that might be helpful to them. And I think genomic counsellors are really well placed to play a role in supporting at that wider level, as well as, you know, in that healthcare setting and supporting that real kind of at the point of care delivery as well.
Yeah, and what are your kind of hopes for the future? I know that you kind of touched upon it just now, but how do you kind of see the future looking? Not just for, I suppose, genetic counsellors, but I think maybe kind of like genomic medicine in general.
Yeah, I think definitely hopeful that it's just a more accessible and available service, and that more people have an access to clinically appropriate genomic tests. I don't think we necessarily want to be saying, yes, everyone should be getting a whole genome sequence for absolutely anything straight away, because we have those variants of uncertain significance that we're still really not sure what they mean. But what I mean is everyone, no matter what background they're from, having equitable access to a relevant test that might help their treatment. So that's, for example, every patient diagnosed with breast cancer having a look at a panel of breast cancer genes that might explain their diagnosis and also give treatment options. And I think that's a really big hope for me in the future. At the moment, genomics services are largely more beneficial and largely see more patients from white and European backgrounds, and that's a lot about what our research data is based in, and the information that we have in terms of being able to interpret those variants comes from studies of white European people. And so a real hope for the future, and I know there is work going into this area, is that we have more diverse populations involved in our research studies, we have more diverse populations that we're able to serve and we're able to support in accessing the testing that they need. So I think that's another hope for the kind of wider services. And I can't not say for there to be more genomic counsellors, because there are lots of us that are in really high demand in the country, and there just aren't quite enough yet. And we really are such a kind of versatile role and can be helpful in so many different ways. And as you've already heard from my few different hats, there are lots of different things that we can do. So I think seeing more genomic counsellors supporting this service is definitely a big hope for me as well.
No, I agree as well. Thank you so much for talking to me today, Beth. It's been really, really interesting, and I'm excited to see how kind of genetic counsellors' roles grow and grow and grow, and hopefully more and more of you as well. So thank you.
Hello everyone, if you enjoyed this video, then make sure you check out some of our other videos in our series by subscribing below or going to our website, frontlinegenomics.com. I hope you enjoy.